Hi, my name is Diane Barnard, and I am a board certified psychiatric nurse, and I am going to teach part one of a six-part training mandated by the state of Florida for mental health training for caregivers. So the course is divided into six sections, and the first one is mental health diagnoses, and that's what we're going to go over right now. So just a couple statistics: common mental health diagnoses in long-term care, which is assisted living, long-term care, any of the types of environments that you may find yourself working with someone who is challenged with a mental health diagnosis, sometimes complicated by physical health as well. So just to put it into perspective, the National Alliance of Mental Illness, which the acronym is NAMI, reports that 1 in 5 U.S. adults experience some form of mental illness, and 1 in 25 U.S. adults experience some sort of serious mental illness in their lifetime. So they're also reporting, because they do statistical analysis, that there's an average delay of 11 years from the onset of symptoms to seeking treatment. So that's a very long time. People are uncomfortable. There's a variety of reasons why they may or may not seek treatment. They may be in denial. They may not have access to good care. People might explain away their symptoms, but there is an average delay of 11 years. And as with anything, when you let things go, they become more complicated and more nuanced and more difficult to treat sometimes. So that being said, sometimes the first time someone is diagnosed with a mental illness is on admission to your facility. So people don't always present with a neat package or list of mental health diagnoses that help you negotiate their behaviors. Sometimes it's your astute observations and your interactions with somebody when you're looking at them with an open heart and in the structure of patient-centered care, that you can actually help someone gain the treatment that will optimize their life and maybe the treatment they never had a chance to get. So long-term care facilities, of course, have a large percentage of older people who lived when the stigma of mental illness was very great. So they may not have ever been treated. And the need for educated and competent healthcare providers to address aging and mental health has never been greater. Thus, the need for this training. So another statistic is the 2017 National Survey on Drug Use and Health reported that about 14% of people over the age of 50 in the United States live with a mental, behavioral, or emotional disorder. That's a lot of people. So as we all know, because we're in the business of caring for older people, and most of these people live in some type of structured assisted living, or they require some type of support because of functional or mental health needs or cognitive needs. We see older people, but nowadays we see more young people, people with IDD, which means intellectually disadvantaged and disabled. So we'll see those types of individuals as well. So the diagnoses that you may encounter in your long-term care facilities, they could be diagnosed, they could have an associated diagnosis, they may be medications prescribed for that, they could be undiagnosed mental illness, they could be treated as with medication or behavioral therapies, or untreated. So that's where your job is to not judge, not label, not avoid, not catastrophize, but really just to be aware and to be alert and astute to the possibility that something else is happening with your patient, and how to raise that concern to the level of a professional that may be able to help that person. So when people enter long-term care facilities or assisted living facilities, all of the individuals really should be screened for some type of depressive response, because if you think about it, when someone comes into a situation, they have reduced the size of their life. They may no longer be in their house. If they're older, they might struggle with grief and loss, loss of identity, loss of income, loss of partner, loss of family, of friends, of animals. So it's a huge adjustment. And so really basically all new admissions should be screened for some level of adjustment, issue, and possibly depression. So what I'd like to go over is some common mental health diagnoses, but there is a book called the DSM-5, which is the Diagnostical and Statistical Manual, and the 5 is of course, how many times it's been written. But really, this book is a very large volume, and it contains all of the mental health diagnoses. And there are many. And for you to be diagnosed, or any individual to be diagnosed with a mental illness, they have to meet the criteria as outlined in this DSM-5. And they have to have so many of these symptoms. It has to last a certain amount of time. So diagnoses aren't just assigned willy-nilly to people. A professional who's been trained in mental health diagnoses has looked at these symptoms. They have lasted a certain amount of time. They've shown a pattern. They have met the minimum number of symptoms to meet the diagnosis. So that's how people get diagnosed with a mental illness. And labels or diagnoses are meant to be helpful and not to be detrimental. But a lot of times they end up being both helpful and detrimental. Because if the person does label them in their mind and expect a certain behavior because someone is bipolar or depressed or anxious or schizophrenic or have dementia, then they may not be aware of things that in the environment or their own personal behavior that might be impacting that patient. So the diagnosis provides some type of little roadmap to care, but it isn't a be-all and end-all for your patient. This person is a sovereign human being in front of you. This person has thoughts and feelings and emotions. We all strive to live our best lives, and so does anybody with bipolar illness, with depression, with dementia, with schizophrenia, with IDD. All of these individuals are human beings who want to live their best life. And when we label them and box them into, this is a bipolar in room 16, she's upset, you know how she is, she's bipolar, when really she's suffering grief and loss from the loss of her daughter. Or perhaps she's upset because you were actually really quite rude to her. When we label people and we stick to that label pretty tight, we lose the opportunity to see the entire context of their lives, and we miss opportunities to help.
So this slide is depression, which is very common in assisted living, long-term care, or any type of patient that's undergoing stress. It's so common, in fact, all residents on admission should be evaluated for it as a result of admission. So even if it's not a pre-existing diagnosis, people should be on the lookout for signs and symptoms, because moving into any type of assisted or group living arrangement is very stressful. There's a sense of loss, and depression should be expected. So some symptoms that you would look for are worsening of mood, poor appetite, crying spells, disrupted sleep patterns, and disrupted sleep patterns could be sleeping too much, not sleeping at all, having nightmares, up and down all night. So anything that's disrupted.
Created with free version for non-commercial use.
Verbalization that they're depressed, that's always a big clue when people are saying that, but they don't always say that, and sometimes they don't even know. And a lot of times when people, particularly older people, begin to fade, people just think that it's a sign of old age, and they just don't consider the fact that this individual could be depressed. Lots of medications can have side effects of depression, so always be aware of what your patient's baseline is and when it changes. And if you don't know the baseline of the patient, if they're admitted in kind of a somber and low energy state, to always entertain the possibility that this isn't their normal this isn't their personality and that there's always something that we can do. Psychomotor retardation or agitation, meaning the slowing down, or they're very, very nervous, restless, whatever. Slowing down and can just be actually the physical slowing down.
Created with free version for non-commercial use.
Slowing down of cognitive processes, slowing down constipation is sometimes aligned with depression. So when the body just seems to slow down overall. Worsening symptoms of pain. Sometimes people that are depressed have pains that don't really have an etiology or a known cause or a diagnosis. And they have vague headaches, backaches, general aches and pains, and they're not, people will call them somatic because they are of the body, but they're not psychosomatic or made up in their head. They're actually, depression actually worsens symptoms of pain. Thoughts of worthlessness, lots of times they don't really talk about it. And then, of course, suicidal ideation is another thing that you would look for.
Created with free version for non-commercial use.
So, let's see. I can't go back. So primary or secondary depression, this is probably the most common diagnosis that we'll find. We already went over briefly why someone being somebody that might have been admitted to a facility may suffer from some depression. Someone might have a lifelong depression and be admitted. And some people might have temporary. Mental health conditions can be acute, sudden impact or sudden onset, or they could be chronic, which is a low, ongoing type of illness. But depression, when someone is depressed, it just isn't a mental or in your head type of thing. It does have the ability to impact all other health outcomes. It's associated with chronic pain. It's associated with poor treatment follow through, and that increases complications. And it's strongly associated with substance abuse. So when we go back and we're talking about, wow, some people wait 11 years to seek treatment, sometimes these people are depressed. We already know that it's associated with poor treatment follow through and sometimes poor access to treatment. You just don't feel like getting up and doing anything. You don't feel like that there's any recourse or any hope or anyone can help you. So sometimes we are the person that leads another person to their healing environment. So secondary depression, we have primary depression and secondary depression. The symptoms are really the same. However, secondary depression is basically caused a little differently, and that is something that we as home health care providers or any type of health worker, we have to be kind of aware. So when you look at someone and you get to know them and you get to know their patterns and you learn how they are as an individual, then you're more likely to understand when that person is off and that they're off their patterns. So for an example, a secondary depression is when the depressive symptoms, remember, present as the same, but it may be caused by a medication side effect. It's common with neurological and endocrine disorders. It can be related to withdrawal from alcohol and or abuse of alcohol. So it's not something in the brain. It's not caused by grief or loss. It's not a long-standing coping thing. It's you have somebody that's usually chipper that comes to bingo on Tuesday who really likes their steak on Thursday, and all of a sudden not coming out of their room, doesn't even care about bingo, kind of sleeping a lot, just kind of flat affected when they're usually very chipper. These are red flags to you. And really, basically, the person that works with somebody is a healing environment. And when you go in and you ask the right questions, or if you're aware or you're paying attention and you know your patient and you know, hey, Mrs. Silvis was just started on a new cardiac med and nothing really has happened. And she said, I asked her, is there anything wrong? And she said, no, everything's fine. and she didn't have any grief or loss issues. We usually have a good rapport. She said she just doesn't feel like herself. That might be something, that observation of yours might be helpful for the doctor to make an accurate diagnosis. So never underestimate your ability to be helpful in the description of the symptoms, both the objective and the subjective descriptions. So the second disorder that we would see frequently is anxiety disorders. And anxiety disorders are groups of disorders characterized by excessive fear and anxious feelings with associated behavioral disturbances. So everybody has fear. Fight or flight is just very, very common. I mean, we all have a fear response. It's what keeps us alive. So you're a little bit nervous about walking out into a dark parking lot. You don't want to get into the elevator. You hear a terrible thunder and you run for cover. Those types of things, that momentary alarm system goes off, it kind of guides you to safety. But when you do that, or somebody startles you, or it's a call to action for you to fight or flight. That your heart starts racing and you start deep breathing and you're super, super aware because you're fighting or flighting. But that's a terrible way for your body to live long term. It's designed to get you out of the immediate danger. It's not designed for your life to live in this constant state. When your body's in a constant state of anxiety, it's damaging. You can't sleep. You can't, your appetite, your digestive system slows down. So chronic anxiety is very detrimental to overall health. But for someone to be diagnosed with an anxiety disorder, it lasts over 6 months. It's excessive in quality and duration of feelings, and there's usually some type of behavioral disturbance, even like avoidant behavior or repetitious behavior, or there's something that they're doing to try to alleviate their anxiety. We all have anxiety. We all get nervous, but an anxiety disorder is very debilitating. So symptoms of anxiety disorders: muscle tension, restlessness, poor attention, sleep disruption, irritability, repetitive thoughts or worry, fatigue, and stress and impairment. So we probably all do suffer from a little anxiety every once in a while, but to live in that constant fear of never being able to sleep, that is extremely difficult to live with. Medications: a lot of anxiety can be associated with medications that are commonly prescribed in our populations: anesthetics, pain medications, bronchodilators, insulin. You don't even think about insulin. There are certain things, of course, something that increases your heart rate. You're like, yeah, okay, caffeine, I'm anxious. But you don't really think about some medications. And what I hope to do is plant a seed in your mind to consider all medications as maybe being a possibility. Everybody's body reacts differently. So perhaps insulin would be something that would cause anxiety. It's not the first thing you think about. Why is my patient anxious? They're diabetic. You're thinking blood sugar. You're thinking whatever. Well, it might be the insulin as well. So again, we're not quick to define or label, but if we notice a change in pattern and we know that they're on a plethora of meds, then maybe perhaps one of those things might be causing them some symptoms, and maybe a different medication would be in order. It's not our job to tell the doctor what to order. Our job is to know our patients, to know their patterns, to know when it changes, and understand what in their environment, including their medication, has changed, and try to help guide professionals such as the doctors into better decisions. Sometimes the patients can't speak for themselves, but frontline workers really know and understand their patients and really should advocate for them. So medical conditions that increase anxiety. So we have seizure disorders, arrhythmias, SVTs, COPD. If you can't breathe, of course, you're going to have a little anxiety. Asthma, yes. Parkinson's, yes. These are all just starter lists. Anxiety and depression, to know the symptoms, if you would come away from this course and know that any type of change, such as a medication or different doctors, changing roommates, what we're looking for is we need to know our patient's baseline. And if they are presenting already at baseline as being depressed or anxious, certainly if they're not treated for it, alert the nurse or the doctor. Now, people can be treated. You may look and know, and she's saying, I've been taking this purple pill Prozac for 13 years. But that doesn't mean because she's been taking it for 13 years, that doesn't mean that it's being effective for her current symptoms. Sometimes we think about when stressors increase, sometimes the need for medication maybe increases as well. For example, if you had a sprained ankle or you had to go to physical therapy, it's probably a bad example, but if you were just sitting on the couch and you weren't moving that much, maybe a Tylenol would be enough. But when somebody who has been pretty immobile then has to get up for physical therapy, we all know to give them their pain medication an hour in advance so they're able to complete their therapy because we've increased the challenges, we've increased the tension. And what I mean by tension is like there's more involved, more chances for pain. So they would require more medication with movement as opposed to sitting on the couch. Same thing with someone who has anxiety, perhaps. Maybe at their baseline when they're sitting at their house at home and their cat's right there and they're watching their soap operas and their daughter's coming to visit and there's very low demands, they may have done very well on a small dose of Ativan. But moving into a new environment, having people prod and poke them, not knowing what's happening, losing their house, they don't know where their cat is, that may have increased their need for some type of environmental and perhaps medication support. So always just be aware of that. So dementia. So we have depression, anxiety, dementia. So dementia, everybody, well, not everybody, and hopefully not anybody after this course thinks Alzheimer's, but Alzheimer's is only one of well over 50 known types of dementia. So a few that you may run into are alcohol dementia, vascular dementia. There's just different types of dementia. They all are associated with cognitive decline, but some of them, well, they present with different symptoms and they certainly respond to different treatment. Alzheimer's disease is the most well-known of them. So with dementia, if you think about it, for the most part, there's some deterioration of brain function and also of form. Everybody knows that Alzheimer's has those tangles. There's some kind of brain decompensation. So if you think about it, if your brain is kind of like the information center for the entire body and it starts to decompensate and kind of lose their form and function, then it's going to impact a whole lot of things like anxiety, psychosis, agitation, aggression, disinhibition, sleep disturbances, because all of those things are governed by your mind. So as your mind begins to, or your brain begins to not work well, then it makes sense that everything that it did before might not work as well as it did, and it could have all kinds of mixed messages and all kinds of confusion. So there's one type of frontal lobe dementia. Forgetfulness isn't the first clue. It isn't the first symptom. Personality changes are the first symptom, and sometimes those personality changes, people don't really notice personality changes unless they're not so good ones. If somebody was normally cranky and their personality changed to be really super happy, nobody's complaining. It doesn't hit the radar as much as when someone is accusatory or paranoid or blaming or hateful. It's very hard for people to take. It's very hard for families to take. Sometimes people with frontal lobe dementia become very accusatory, paranoid, delusional, with fixed delusions. It's very difficult for the families because the families blame themselves. They'll say, well, I don't know why they're doing this. I never did anything to her, without really realizing that it's not the patient, it's the disease process that's affecting the frontal lobe of the brain, and therefore there's personality changes. So that's one of the things that's really hard to take in long-term care when your patient is accusing you of stealing, calling you names. And sometimes it's not just a nasty person. Sometimes it's a person with a very progressive and very detrimental brain disease. So schizophrenia is a severe mental illness, and it's usually a lifelong thing. It's usually diagnosed in the late teens and early 20s. It's characterized by delusions, hallucinations, disorganized speech and behaviors. And because if you can just pick just a couple of those delusions, hallucinations, disorganized speech, behaviors, it makes a little bit of sense why these people might end up in placement or in some type of supervised setting as opposed to being able to live on their own, because they don't have the executive function sometimes to be able to negotiate life outside of an institutionalized setting. These individuals are institutionalized frequently or historically very early in their lives, on and off. So they acclimate and they become very comfortable within the institutionalized setting, and sometimes they pretty much spend their whole life in and out depending on the severity of the disease. So the illness, schizophrenia, is associated with neurocognitive deficits, impaired executive function, like I said, and a lot of social dysfunction, which makes it very hard. Oops, let's see where I'm at. So substance abuse disorders are another thing that you'll see. Life is hard. The older you get, sometimes the harder it gets. I know that I did a study in Pennsylvania where I think a large number of opiate users were in the 12 to 25-year-old group. And I was astounded by that, 12, because I was taking a graduate course and I had to do a community health awareness survey or whatever, and on how to improve some type of outcomes. And my goal would be to do drug screening, opiate screening in pediatrician's office. And I found that so incredibly hard to believe. You would think that you would be doing it for mostly adolescent medicine, but if there was a large number of overdose at age 12, that would mean that the screening and intervention should start really in the pediatrician office. So our world is hard. It's getting harder, and a lot of people come with substance abuse, either legit or illegitimate. And that's just something that we need to be aware of, and we need to be supportive and get help for, and understand that it's going to be a challenge. People that can't drink alcohol regularly in placement or gain access to illegal substances could act out or have behavioral issues. So, which brings us to behavioral issues in long-term care. So the one thing that I wanted to say about that is that behavioral issues are not always associated with mental health. And if I could plant, really these are just a half an hour long, and if I could plant any seeds for someone who is taking this course, is that you have to be an astute observer. You have to suspend any kind of behavioral or mental health labeling. When someone comes with a diagnosis, it's designed to be a roadmap to care. It's designed to maybe bring some clarity to match some type of treatment that the individual is getting. It is not meant to label them and put them in a box or define them as just that diagnoses, because people are so much more than their diagnoses. So that being said, every human being that is in your care has thoughts and feelings and hopes and dreams and wishes and needs and has grief and loss. It has the whole package. Everyone alive, IDD, schizophrenic, dementia, depressed, someone with no diagnosis at all. They all have the same needs. So that being said, and when we know that the environment is already one somewhat of loss, then we know that our interactions with people can be part of a healing environment or part of a not so healing environment. So what I'm asking you to do when you interact with any person would be to think about what your interactions. Were you open? Did you use active listening? Did you judge what they were going to say? Did you anticipate what they were going to say? Did you really learn how to listen to what they needed? For example, if somebody was very thirsty or wanted something from you and you did not accommodate or listen or hear them, and they became annoyed, and they also have a diagnosis of bipolar, then really basically, if you didn't realize how you played into that interaction, then the outcome is not going to be good. People have a right to be upset with people, whatever their diagnosis. So you always have to be super aware of how you have contributed to any type of ongoing situation. So behaviors could be a part of their mental illness. They just could be a natural outgrowth of grief, loss, anger, depression, any range of emotion that you may feel in the course of a day. Also, the environment could be soothing. It could be chaotic. It could be loud or frustrating. The person might not be able to sleep. So you have to be a detective. So let's say somebody is next to the kitchen and the kitchen starts making biscuits at 4 a.m. and this individual usually always sleeps till 8. But since the new worker came in and started playing the radio and making the biscuits, they never played the radio before, they have to wake up at 4 a.m. every morning and they're cranky all day. They have 4 mental health diagnoses, but they were never cranky before. So all of a sudden they're cranking, they don't want to come to breakfast, they're like, get out, you people keep me up all night. So this individual actually has a legitimate reason to be angry. It's not their mental health diagnosis. They might not be able to cope or explain what they need very well, but the behavior itself isn't really an outgrowth of the mental health diagnosis. It's an outgrowth of the person being kept up all night. Does that make sense? So when you're looking at a behavior, you always look at the behavior for what it is, and you look at the context of what could contribute to it, what could alleviate it, and that makes for a happy client, a happy staff, a happy facility when people all get their needs met. So the other thing is some behaviors are medication side effects. So I always ask people to be just astute observers, to ask the next question, not to label the behavior, not to be quick to judge, not to be quick to decide that you understand the meaning of somebody else's behavior, to try to figure out what a solution is that meets the patient's needs, that meets your needs, and to meet the milieu or the therapeutic environment of the entire facility. Common behavioral issues in long-term care: yelling, hostility, verbal aggression, physical aggression, and care refusal. I think for the most part, most people want to have a nice day. When people are yelling and hostile, verbally aggressive, or physical aggression, they could be afraid, they could be hurt, they could be scared, they could be angry, they could feel grief and loss, they could feel a loss of control. Care refusal is not usually, but sometimes and a lot of the times, just a loss of control. And you can do that for somebody. If somebody doesn't want their bath, doesn't like a bath in the morning, but you have a certain schedule, you could say to that person, you could give them some control by saying, says, I don't want a bath. You could say, Mrs. Silvas, I'm here to give you your bath. Would you like it now? Or would you like to eat your breakfast first and I'll come back at 9? So you're not letting them out of a bath, but you're giving some control to them. It's very healing for people to have a little bit of control in their life. It's not a lot. It might make your day or may push your break back 10 minutes. What you're doing is helping this person have some control in their life and creating a great rapport and possibly a better day for you and the rest of your staff and the patient. So I talked about how you need to examine the patient and the surroundings for triggers of problem behaviors. Just zoom in and zoom out. So much is to be learned by zooming in. Zoom in on the behavior. What are we looking at? What does it mean? Blah, blah, blah. Then zoom out. What kind of things could contribute to it? What am I doing? What are they doing? Is there noisy? Is it chaotic? Is this schizophrenic individual that doesn't like noise? Are they having a drum circle in the next room? Like, sometimes it's that easy. You're like, oh, okay. When somebody's overstimulated, are you trying to reduce the stimulation in the environment? Bright lights, loud noises, people yelling. Trying to know your patient well enough to match something to what calms them, what soothes them, helping them soothe themselves. And that's it. And I have some questions for you to go over, which you guys can go over by yourselves and go through them. I have the answer. Thanks for listening, and I'll see you on the next course.